Well, hello, welcome everyone. Happy Wednesday. Thank you for joining me today. My name is Hiva Kolodrovitz. I'm a family nurse practitioner here with Archer Review, and today's webinar is all about diabetes, and we're going to get focused in on pharmacology. Thank you for joining me today. Welcome, everyone. I see a few friends from our live session on Instagram this morning. Welcome, Anna. Welcome, everyone who joins us through Zoom, through our YouTube channel, and through our Facebook group as well. Um, for those of you who have never attended my lectures before, I will tell you that I really like to keep it engaging and interactive. We have our lovely Miss Rachel Ward on our chat today to help with chat support, but I use a lot of different tools other than just chat to really help you guys feel like you're part of a classroom setting. My goal is to teach you something not just for your boards exams, because here at Archer, we're not just a test prep company. We are here for you as a whole nurse, and that means supporting your clinical practice. So my goal is to really teach you something today so that you can apply it to not only your boards exams and show them that you're a confident and competent nurse practitioner, but you're also going to succeed in clinic when you're taking care of these diabetic patients. So with that said, the tools that I like to use in our webinars, one of them is called Slido. And we've been doing it now for a couple of months in our Archer webinars. So for those of you who have joined other Archer webinars, you're probably familiar with it. You might already know about Slido through other forums. But I really like Slido because it's a fun interactive tool, and I have a couple of fun polls for you this morning just to get us warmed up on Slido. But for those of you who don't know, you can join in two different ways. You can scan this QR code and it'll take you to slido.com and it'll take you to the polls directly. And I have our first poll already launched this morning of where are you joining from. Or if you don't want to scan the QR code, if you don't like to toggle back and forth on your phone, which I've done as a user before, and it's nice because the video does pop up in the right-hand side, so you are able to participate with the polls as well as still see the presentation, hear the presentation. But if you don't like doing that, you can always join Slido on your computer by going to slido.com, and then you just have to enter this hashtag DM Pharma, and that'll take you to the polls that we'll be using today throughout our presentation. So how am I going to be using these polls? I'm going to be asking you practice questions for your boards, and I'm also going to be walking you through a case study. And there are a lot of different types of polls, including open text, word cloud, rating systems. So it's fun, but it's also anonymous, which I think users like a lot because you can really take your guess and be brave and tell me what you think the answer is or what you think we should do in that free text when we get to the case study bits. And your name does not pop up there. And that way you can see your peers' responses and you can see kind of what other people are thinking and really get that engagement while maintaining that anonymity. So don't be afraid to participate. It's really my goal for today is to have fun with this. Pharmacology can feel a little daunting to people, especially when we're talking about diabetes. That can always feel like a big, like, oh, what do I do with all these different classes? We're really going to try to break it down today and have fun with it. So please participate. You'll get a lot more enjoyment out of it that way. So without further ado, our first poll, where are you joining from? And you guys have already figured it out. Awesome job. You can go ahead and free text where you're joining from. So hello to those of you joining us from Connecticut, New Mexico, Florida. And I really like these polls because you get to see, like I said, what your peers are saying. And then you also get to see, kind of where everyone's at. And so we get a lot of both international and national students who join us for these webinars. And it's fun to see that some people are joining us from like Germany or Australia. It's a lot of fun. I like to see where my students are from. I personally am from the Massachusetts area. I've practiced out in California and now I'm practicing in Texas where I currently live. So I've kind of been at all the little corners, East Coast, West Coast, and now the South. So it's fun to see how the nursing community kind of changes based on where you are, but we're all still nurses at the end of the day. It's really nice. So if you're familiar with word clouds, as you're typing responses, the one that's getting the most response is getting bigger and bigger. So you'll see here that we have probably a few people joining us from Connecticut, and that's why Connecticut's so big, which is great. Welcome, welcome. And we have some new responses from Ghana. Awesome. Welcome in Indiana. So very fun. Glad to see you all. We're going to go to our next fun poll. You guys have got the hang of this word cloud, which is great. We'll be using the word cloud throughout today's presentation. And who's in the audience today? So tell me a little bit about you. Are you a registered nurse? Are you a nurse practitioner student? Are you both, right? We're all registered nurses going into our NP programs. Are you already a nurse practitioner? Did you finish your boards and you're getting ready for your first clinical job? How are we feeling? How are we doing? If you are an FNP or NP student, tell me where you are in your coursework. NP waiting to take your boards. I see some NP students currently RNs. That's great. I think that's a really hopeful and exciting time, but it's also a very nervous time, right? So you're wondering what's going to happen, especially with healthcare being so um, front and center in our politics currently. But a lot of FNP students waiting today. A couple of you are waiting to take the exam. A few of you are graduating this coming August. That's exciting. That means you're in your clinical rotation this year. So this is going to be really helpful to you, hopefully, as we're talking about these case-based scenarios, because you can't get experience without getting the experience, right? And our case-based scenarios are the best way to really mimic that experience in the clinic so that we can really absorb and think through a lot of those critical thinking processes. We see some adult gerio NPs. We see some BSNs in the audience. This is great. Really, the diversity is wonderful. And are you adult acute or adult primary care? I see a critical care nurse in Ghana, hopefully starting a DNP program soon. That's awesome. Congratulations and welcome. Thank you for joining us today. Love our critical care nurses. You guys do such important work. All our nurses do such important work. This is really a wonderful, supportive community and platform for all of us. So our adult gerio is in primary care, very needed right now with our geriatric patient population, all our boomers, right? Not enough primary care providers out there for all of us. So thank you for joining. We got another international person joining us from Nepal. Welcome. And we have a NP graduate, recently graduated. So very exciting times. We're all kind of in different phases of our nursing career, but I think we all can really benefit from diving deep into the pharmacology of diabetes, because whether you're an RN, NP student, recent new NP, new grad, you're going to come across patients who have diabetes, and you really need to get comfortable with how to manage their diabetes. So welcome to everyone. Last fun poll just to get us warmed up so you guys got used to this free text poll. Last poll to get us warmed up is just like a little rating poll just for fun. Which do you like better, chocolate chip cookies or fruit smoothies? I was trying to come up with like a salty and sweet option just to see if I can get a contrast. But then I thought of it and I was like, well, I guess they're both sweet, but I'm the kind of person who likes to eat around the chocolate chips and the chocolate chip cookies. I think my daughter is like, what? Why do you not like the chocolate chips? But I like the dough. So when I'm baking them, sometimes I'll put a couple in there without some chocolate chips for myself, but it doesn't really come out with the same consistency. So I eat around the chocolate chips. But what do you guys like? Fruit smoothies, chocolate chip cookies? Which one do you like better? And I think if I were to answer the poll, I think I personally would enjoy a fruit smoothie right now. That sounds nice. It's like 80 degrees in Texas today. I don't know why. It's February. All right, you guys, awesome job with the polls. We're going to get into the content, but that's going to be our Slido. Keep it up on your phone, computer, however way you got in there. And we're going to be going back and forth between our slides and our Slido today. All right, so just to get us all on the same page and get us kick-started, Remember, diabetes is chronically elevated blood glucose level. So this is a disease where your body has really been struggling for a long time. And this is not like a spike in your blood sugar levels once or twice here or there. This is a chronic condition, right? Two main types that we're going to focus on today are type 1 diabetes and type 2 diabetes. In primary care, as nurses, as primary care clinicians, you're going to be managing both of these patient types, right? Both of these types of diabetes. Typically, our type 1s, yes, those will get more managed by our specialists, but you may be seeing a type 1 in your clinic and catching it and diagnosing it for the first time and getting them over to the specialist, right? So getting familiar with the process of what constitutes as type 1, what constitutes as type 2 is really important, and how to manage those two patients until we get them over to a specialist if they're really complicated. I'm not going to go deep into the pathophysiology between type 1 and type 2 and how to diagnose today. If you guys want that, I've done that in previous diabetes lectures, and you can go onto our Facebook group and watch those videos. We also have our on-demand videos. I've recorded over 3 hours just in endocrinology, where we really dive deep into anatomy, physiology, pathophysiology of diabetes, how to diagnose. But for today, I'm going to keep it high level so we can get to the pharmacology. But just remember, your type 1, that's going to be your autoimmune condition. That's when really the body is destroying those insulin producing beta cells in the pancreas, right? Typically, we'll see this more in childhood. It does peak between the ages of 4 to 6, which is really tough, right? Imagine a 4 to 6-year-old getting diagnosed with type 1 diabetes and the burden that comes with for both that child getting those injections as well as the family, right? The emotional burden, the financial burden. It also peaks in early adolescence, so in early puberty, and that's really before the age of 10 is when we're seeing these diagnoses of type 1 diabetes. Now we're seeing a lot more research. We're getting a lot more education as clinicians in diagnosing type 1 in our adult patient population who are kind of on the cusp, maybe because of pancreatic fatigue. But for the purposes of your boards exams and really not looking for zebras, you're going to be thinking about type 1 diabetes as your childhood, more common as your childhood disease. Type 2 diabetes is going to be more metabolic dysfunction. So this is the classic type 2 where we see the obesity, the poor diet, the family history. It's not exclusive to our adult patient population, right? We're seeing it a lot in our pediatric patient population, especially with obesity on the rise. So we have to be mindful of this as we're looking at our adolescents who are going through puberty and how they're doing with those lifestyle choices and what their family history looks like. So this is more about metabolic dysfunction, insulin resistance, insulin deficiency, again, that pancreatic fatigue or overload over time. And this is going to be the majority, 90% of our cases. So the two main ones, type 1 and type 2 diabetes. Some signs and symptoms of diabetes. Now, we may all be familiar with like different acronyms, or these are the typical signs and symptoms of diabetes. Again, I'm not going to get too deep into the pathophysiology, but I want you to be thinking about why we're seeing these signs and symptoms in our diabetic patients and not just checking it off the box, because you want to be thinking when you're having these conversations with your patients and they say something, you want to be thinking, wait a minute, is that their diabetes in their body and they just don't recognize it? Because remember, they're not medically trained. We're medically trained. So we need to understand what's happening with the body. So that increased urination, remember the kidneys, the body's really trying to maintain that homeostasis. So if you have elevated blood sugar levels, the body's going to try to dump that. And one of the big ways is through the kidneys. And one of our drug classes helps support that. We'll talk about that in a minute. But it's really going to try to get rid of that glucose in that bloodstream to get those levels back down. So that's why you're seeing increased urination, right? With increased urination, you're getting dehydrated. That patient's going to be really thirsty. So we'll see the increased thirst. Thrush, genital itching. Remember, your genital area, dark, warm breeding ground for a lot of bacteria overgrowth. throw in extra glucose in there, and you're going to get a lot of risk, high risk for infection. You're going to see that infection a lot, especially with our diabetic patients in the skin folds as well. We're going to see it a lot. Slow wound healing, same idea, right? If you have high blood glucose levels, that wound is going to take a lot longer to heal because the bacteria has some yummy food to feed on, right? So it's going to take a lot longer. That slow wound healing, we'll see it. Blurred vision, oftentimes you'll see the buildup of glucose on the front lens of the eye. So you'll have some patients coming in complaining of that. You'll also see fatigue. Why are they going to be fatigued? Because their body is not getting the energy they need. So they're eating the food, the glucose levels, the blood sugar levels are staying high. All that blood sugar needs to be moving into the cells to help those cells get energy, produce ATP, and it's not getting there. Whether it's because of that metabolic dysfunction or just not producing enough insulin, it's just not getting there. So patients are chronically fatigued. Their body is desperate for that energy, so it's going to start breaking down its fat reserves. So initially you'll see some weight loss. And then with that fatigue, with that lack of energy in those on the cellular level, you're going to see that increased hunger because the body's just starved, right? Even though our patients may be gaining weight. So a lot of things to think about with these signs and symptoms, but as you're studying, I really want you to be thinking and not just memorizing, right? That's going to be the most helpful to you. So quick poll, we're going to go to our next poll here. What do you guys think? Would you see these signs and symptoms in a patient with type 1 diabetes or type 2 diabetes or both? What do you guys think? I want to make sure you can see my poll. We're active with the poll. I see some responses coming through. So some people think we'll see it in type 1s. We'll see it in type 2s. Some people think both. Absolutely. So we're going to see these signs and symptoms in both type 1 and type 2 diabetes because remember, the process is the same. The issue is those high blood glucose levels in the bloodstream, right? With type 1s, the issue is not enough insulin. With type 2, the issue is probably more of that deficiency with that lock and key, but in that metabolic resistance, but the issue is still the same. It's chronically elevated blood glucose levels. And that's why students kind of get a little tripped up with diagnosing. First, you have to diagnose the diabetes. Then you have to figure out, is this type 1 or type 2? Some cases are pretty classic. Some cases are a little bit more challenging. All right, awesome job. So just another brief overview before we get into the different drug classes. Remember, hemoglobin A1C, this is our average blood glucose over a span of 3 months. So please, when you're out in clinic, don't order these A1Cs more than every 3 months in frequency. I see different clinicians ordering it around the clock. You don't need to do that. Patients are going to get pinged from insurance. They're going to have to pay high dollars for those labs. You can use an A1C that somebody else ordered, and you're not going to be ordering it more frequently every 3 months because it is an average of your blood glucose across 3 months. And so our normal is going to be less than 5.7. We're in that pre-diabetic range. What does that mean? Pre-diabetes. That means the body is showing some early signs of insulin resistance. And so that pre-diabetic range is really around 5.7 to 6.4. And then our diabetic range or qualification or classification is really an A1C over 6.5%. You can use other things as well, like a fasting glucose to diagnose diabetes, but A1C is also part of your diagnostic. So this is also one tool for diagnosing diabetes, but anything over 6.5%, and that is a diagnosis of diabetes. What do you guys think? I'm going to launch our next poll, but what do you guys think is our goal for A1C once we've diagnosed a type 2 diabetic patient, and let's say they're younger than 60 years old, they're healthy otherwise, what is going to be our goal A1C for our type 2 diabetic patients when we're continuing to manage their diabetes? Where do we want to get them? Do we want to get them less than 8%, less than 6.5%, less than 5.7%, less than 8.5%? What do you guys think is our goal? And I see a couple of responses. Looks like you guys are getting the hang of Slido. I love it. We Yeah, what do you guys think? Remember, this is all anonymous, and it's fun to see what your peers say. We're kind of deadlocked here. Up 6.5%, gaining some lead. No one's going for the 8.5% of the 5.7%. Yeah, so our goal is to really get them under 6.5%. Again, we're not talking about our geriatric patients. This is our 60-year-old type 2 diabetic, otherwise healthy. Awesome job, guys. Very good. All right, so when we're talking, oh, yeah, let's do a little brain pause. Let me make sure I'm on the right slide for you. So if all of that sounded good, but maybe you need just a little bit more of a deep dive into that anatomy, physiology, pathophysiology that we just talked about, you can definitely check out our on-demand videos. Like I said, we do a really deep dive, but we break it down into bite sizes so you can navigate those videos where you want to go. But you really need to revisit some of that foundational things that we kind of did a high-level overview of if you felt a little bit lost. Because when you're getting into pharmacology, if you don't have the foundation of the anatomy, physiology, then the pathophysiology is going to get a little bit more challenging. And then the pharmacology really follows that pathophysiology. So if you don't understand the pathophysiology, you're going to just be memorizing the pharmacology. And that's not something that's going to stick when you're out in a clinical setting or when you have test day anxiety. So I really want you to get a good foundation, and you can utilize a lot of our resources. We do free webinars. So if you join our Facebook group, you can go and utilize those free webinars where I've done a little bit of a deeper dive into that pathophysiology. You can also utilize our on-demand videos or just mentoring if there are things that you're like, I just don't get this. I need a little bit more of a deep dive. Can you help me? You can also tap into our mentoring. Okay, so before we go into these drug classes, I'm going to launch our next poll. I want to see what everyone's comfort level is with our anti-diabetic medications. And I think I used my emojis on this one. No, I used my star ratings on this one. I think I switched this poll around. And I used to use the emojis where it was like a crying face, and that's okay if you feel like you're in that crying face phase of your pharmacology with diabetic medications. I think that's where I was when I was going through clinicals, and I had the luxury of going through most of my rotation in a federally qualified healthcare center, which cared for a lot of patients with these chronic conditions, including diabetes. So I saw a lot of this and got a lot of practice. But even then, I just felt like, oh my goodness, like where do I start with these patients? How do I get them to be compliant? These patients are so complicated. So I think I definitely was that crying face emoji when I started my clinical rotations with our diabetic patients. So please don't feel like you're alone. We all start in that crying phase when we're talking about the anti-diabetic medications. But I see for the most part, most of us are kind of across the board, but maybe not feeling as confident. And that's probably why you joined this webinar today. So I'm so glad. Hopefully you'll feel more confident as we go through the different drug classes. So two different sources of guidelines to really help you when we're talking about managing, especially these type 2 patients where we're talking about oral medications. And now there are just so many different classes of oral medications out there. So where do you start? Where do you add on? How do you go case by case? Right now, we have the American Diabetes Association, and this is an independent nonprofit organization, and their guidelines are still up to date and on their website, which is great. This is a great resource. We also have the American Association of Clinical Endocrinology, ACE. I really didn't start using ACE until I went into endocrinology and really started to see more type 1 patients. The ADA does a really good job with the type 2 management, but you have both as a guiding resource, and they're both independent from the CDC. So those guidelines are updated and there for you as a nurse and a clinician. So let's get into our first class of medication, our sulfonylureas. These are the medications, if you're looking at the generic, so we have the generic in the lowercase, we have our brand names in parentheses here, just to orient you to the slides as we're going through pharmacology. I'm going to be talking about the pharmacology, and then we'll talk about side effects and contraindications. Dosing is really going to be drug specific, so I'm not going to focus and get too nitty-gritty into the dosing, but I'm going to highlight some important things about dosing for that general drug class as we're talking about it. Remember, with pharmacology, safety is always first, right? That's going to be at the top of your brain when you're prescribing. You want to make sure you understand what you're prescribing, you know what to educate your patients on, and those are the types of things that the boards is really going to be asking you about, are safety questions. So when you're studying, be thinking about safety and what you really need to be focusing on with those side effects and those contraindications. You're not going to really understand the side effects and the contraindications unless you understand the pharmacology. So again, that's why we really need to continue to build on these foundations, right? So your sulfonylureas, these are the medications when we're looking at generic that end in the suffix "ide." So you have your glyburide, your glipizide, your glimepiride. And the pharmacology here, so this is our oldest and cheapest class of medication. It's falling out of favor, but in some patient populations, this is all that we have due to insurance issues or financial issues because they are still the cheapest out there. The way it works, the pharmacology is it really helps increase that release of insulin from those beta cells. And so what do we know about the difference between type 1 and type 2? If you don't have beta cells that are functioning, this is not the class of medication for you. So look at the contraindication. Type 1 diabetes right there in the contraindication. So do you understand how if you learn the pharmacology, it really helps guide you to all the other stuff, right? So with that increased release of insulin from those beta cells, you're going to get increased insulin sensitivity, right? So you're going to get, it's going to do a really good job of moving those high blood glucose levels into the cells. So if it does too good of a job, what happens? Your patient can tank, and then we deal with hypoglycemia. So that's going to be the biggest side effect with this drug class, and that's why it's falling out of favor because of its high association for hypoglycemia. So with dosing, what we're going to focus on with this class is we really want to make sure we're educating our patients on not skipping meals. We have to take this medication with meals, and then we're going to be really gradual when we're increasing this medication because we really want to be watching for signs and symptoms of hypoglycemia. It also works in the liver. It decreases that glucagon secretion, again, working in trying to help drive down those blood glucose levels. Weight gain is another one I wanted to highlight because with sulfonylureas, when it does a really good job of moving all those high blood glucose, blood sugar levels into the cells, the body takes what it needs and then it stores the rest. So we do see some weight gain with adipose tissue with this class of medication. So maybe not the best class of medication in a patient who's struggling to lose weight and they're really working hard on losing weight. All right, moving on to our TZDs. These are our drugs with the suffix glitazone. And so when you get out to practice, you'll get more comfortable with using the generic versus the brand name. You'll kind of get into your groove and your style. How does the pharmacology work? It really helps improve the insulin sensitivity. The biggest side effect is that fluid retention with this drug class, right? The way this drug class works, it really increases the reabsorption of water through the kidneys, and that results in that fluid retention. And that's why we really have to be mindful when we're prescribing this class of medication about heart failure. So it's contraindicated in our patients with heart failure, especially class 2 through 4, because with that fluid retention, really, if you have studied heart failure yet, or maybe you're going to be studying it soon, with heart failure, we really need to be watching those fluid volumes in the heart, right? So this is contraindicated in that patient population. And it's something that you have to be mindful of and educate your patients on signs and symptoms. If they start to see any signs and symptoms of really fluid retention that's becoming an issue leading to heart failure, they need to stop the medication and let you know right away. So TZDs, remember, heart failure, based on the way it works, because of all that fluid retention, we really need to monitor for those signs and symptoms, shortness of breath, rapid weight gain, that lower leg edema. It's going to be our biggest red flags. The other thing that comes with all that fluid retention is weight gain. So again, it's mostly water weight, but it does cause increased weight gain with this patient, with this drug class. So again, maybe not the best option for patients who are trying to lose weight. The biggest thing with dosing is really there's a long half-life, so it takes a while before it reaches its max effect. So you don't want to titrate this any sooner than every 4 weeks. You're going to go really slow with this class of medication. And then there's also an associated risk of osteoporosis, but really biggest thing to know about TZDs, if you take one thing away, is going to be that fluid retention and that risk for heart failure. All right, moving on to biguanides. This is my favorite drug class, and if you've heard me lecture on diabetes medications before, you'll know this is my favorite drug class. Metformin is the only drug available in this class. We used to have fenformin, which was previously also in this biguanides drug class. Fenformin got discontinued due to its strong association with lactic acidosis. We don't see it as much in metformin, but that's why we do make sure that we're watching the kidney function with patients on metformin, and we want to really make sure that we're not prescribing it in patients who really have like end-stage renal disease or severe liver dysfunction, because we want to make sure they're clearing this drug, right? But let's talk about the pharmacology. So it decreases the absorption of glucose in the intestines. It mostly really works in the intestines. So of course the side effects are going to be GI, right? So a lot of patients will come in with those GI side effects of nausea, upset stomach, loose stools. Those are common, right? So you really want to educate your patients on what to expect so that they don't say, oh, I can't tolerate that medication because I had some nausea, some stomach upset, some loose stools. That's actually expected because of the way it works. When patients stay on this medication, their body will get used to it and those side effects usually subside. The biggest thing to note is that if you start low and go slow, which we know is best evidence-based practice, we want to always start low and go slow. But that typically tends to help minimize the side effects and patients get used to the medication a little bit easier. I hate seeing patients get started on 1,000 twice a day or 1,000 even right off the bat, because they will have a punch to the gut, if you will, and then they will say, no, I'm never trying that medication again. And this is really a shame, because this is a good medication. The way it works, it really helps increase that uptake of glucose in the peripheral tissues. So it works with that lock and key mechanism, and it really helps get those blood glucose levels into the cells. And it lasts for a long time. The research is really good on this. Even patients who have stopped taking the medication, 6 months later, we're still seeing the benefits of this medication. So I really want my patients to stick with this medication. I really want your patients to stick with this medication. So start low and go slow, and talk to them about expected side effects. It also helps in the liver. It works in the liver by reducing that hepatic output of glucose as well. But biggest takeaway with metformin, really those GI side effects. It works with that reuptake of that glucose in those peripheral tissues, and you want to start low and go slow. Make sure their kidney and liver function is healthy, and they can screen it. All right, so let's get to our first practice question. We're going to go to our next poll, poll 7, and we'll read this together. In planning pharmacologic treatment for a geriatric patient with diabetes, which of the following should be considered? What do you guys think? Is it A, B, C, or D? Would you start them on a sulfonylurea, like a glipizide as your first-line therapy? Would you start them on insulin? Would you start them on a combination therapy? Or would you start them on metformin as your first line? What do you guys think? A, B, C, or D? Go ahead, tell me what you think. Across the board, you guys got it right. So metformin is correct. And so why are we starting them at metformin? Again, remember, metformin is such a safe medication. It's really always going to be our first line unless we have a contraindication, which is usually rare. And that, especially our geriatric patient population, I really do not want to start them on a sulfonylurea or insulin if I don't have to, because of that hypoglycemic risk. And then, of course, C, we all know best practice. You're not going to start a patient on a combination therapy like a glipizide metformin. Again, that glipizide is a big no-no with our geriatric population with that risk of hypoglycemia, and you would not be starting on a combination therapy as your first line. Awesome job, you guys. All right, so SGLT2 inhibitors, these are a close second of my favorite, and especially now that we know so much more about SGLT2 inhibitors. These are our medications that end in the glyphosomes. So you have your Invokana, Farxiga, Jardians. And again, you'll get more familiar with the brand names, but when you're studying, you can study those generic names with the suffixes. How does this class of medication work? It really helps. It works by decreasing the absorption of glucose in those kidneys. So remember what we talked about in the beginning. How does the body try to maintain that homeostasis through the kidneys? Really tries to excrete that sugar, right? SGLT2 inhibitors do the same thing, work really mainly through those kidneys by decreasing that reabsorption of glucose in the kidneys, trying to promote that glucose excretion, and with that comes increased urination. So side effect, increased urinary output, very much expected. With that, again, same side effect as what happens naturally in the body. You're going to get an increased risk for those yeast infections, those UTIs. With our geriatric patient population, this is not my favorite class of medication because we do have that risk of hypovolemia, right? With all that fluid going out, I don't want to dehydrate my geriatric patient population. And if I have patients on this class of medication who have been on it for a long time, and we're now having the conversation about backing off of their A1C goals, this is, if they're on an SGLT2 inhibitor, this is going to be the first class that's coming off for me. These are expensive, and the risks are just a little bit too high for my geriatric patients. You also have a risk of hyperkalemia. Again, I don't want to be playing around with cardiac issues. So I'm going to be taking my geriatric patients off of this medication if I can. So you really want to be watching for that dehydration and infection. A nice little benefit of this class of medication is that weight loss. So initially it's water weight, but eventually it does really help with actual adipose tissue loss and fat loss. So this could be beneficial in your fairly younger type 2 patients who really just need a little bit more help with their blood sugar levels as well as with that weight loss management. Last thing I'll say about this drug class is that the reason why it's my second favorite is because now we do see that it has really cardiorenal protective qualities. So it protects your heart and your kidneys, and it's now been approved. You guys probably already know, but it's been approved in our heart failure patients who don't even have diabetes. So it's no longer just an anti-diabetic medication. We're going to be seeing this a lot more used in primary care. Right now, cardiology is pretty comfortable with prescribing, but the drug reps are really trying to push this in the primary care world. So I think as primary care clinicians, you guys are going to be seeing this a lot more and getting more comfortable with prescribing this if your patient's insurances will cover it. So that's a big caveat. All right, our GLP-1 agonists. So these GLP-1 agonists have gotten a lot of buzz, and we all know why. Go ahead and put it in the chat for me. Why do we know about our GLP-1s, you guys? Yes, absolutely. For weight loss, right? So GLP-1s, they're anti-diabetic medication drug class. And initially, that's what they were approved for. We saw really great benefits of weight loss in this drug class. So then, of course, they started getting approval by the FDA for just weight management. So we get the Wegovy's and the Zepbound and the semaglutide compounds that everyone's trying to get because you can't get your hands on GLP-1s for weight loss. Now, how does this class of medication actually work? What is a GLP-1's role in the body? Remember, it's a GI peptide. It gets released in response to food intake, and that helps stimulate that release of insulin. And that also slows that gastric emptying. It decreases that glucagon secretion from the liver, and then it also increases satiety so the patients feel more full. So if all that sounds familiar, no wonder we're going to get a lot of GI side effects, right? All that gastric slowing and emptying, the satiety, GI is the biggest complaint that we see with this drug class, but patients are willing to put up with it for the weight loss benefits. I'm not going to go into a weight loss lecture today. Actually, our colleague Morgan does a really nice lecture on weight loss medications and goes deep into GLP-1s. But you really want to talk to your patients about the importance of making sure they're eating a diet that's high in protein. We're seeing a lot of muscle wasting with these GLP-1 agonists, and it's because of that increased satiety. Patients just are not as hungry when they eat. They still have those bad habits. They're snacking on bad foods. And so what's happening is they're not actually losing that adipose tissue, but more muscle mass. And that's actually setting them up for failure once they come off these medications. We really want to make sure we're maintaining muscle mass and losing fat. So we need to talk to these patients about diet and lifestyle if we're prescribing this drug class. I will leave it to that for weight management and in our diabetes patients. So GI symptoms are going to be the biggest side effect. We really want to watch for signs and symptoms of pancreatitis. There are also FDA is investigating some reports of changes in mood and behavior, so increased risk of suicidal ideation with this drug class. Let's see what comes in the future with this drug class. Right now, it's not contraindicated, but I have to be honest, when I'm prescribing, if I have a patient that I know has been struggling with depression, I will try to get them, I will not prescribe GLP-1 agonists, and I will try to get them on a different medication, whether it's for weight loss or their diabetes management. The other risk is thyroid cancer. So if they have a personal or family history of medullary thyroid carcinoma, this is a big no-no. It's contraindicated. And if you're prescribing GLP-1s, you want to document that you screened for that, right? And the patient denied and said no. Put that in your documentation. That's really important. Patients with already delayed gastric emptying, do not put them on a GLP-1. Remember the pharmacology, it slows that gastric emptying. If they already have delayed gastric emptying, this patient's going to wind up in the hospital with an obstruction, and that's not good. So gastroparesis, delayed gastric emptying, you do not want to give in those patients. So be mindful of that. Patients will try to convince you otherwise, but be mindful of that. And pregnancy and breastfeeding, sometimes those you do have to unfortunately memorize, but it is contraindicated in patients who are pregnant or breastfeeding. So in our younger moms, we definitely want to be talking about family planning. And if that's something in their future, not the right medication option for them if they're looking for weight loss options. Our DPP-4 inhibitors, these are drugs that end with the gliptins. So that's your sitagliptin, saxagliptin, more commonly known as Januvia, Tradjenta. These medications, so the way I always think about our DPP-4 inhibitors, what is the role of DPP-4 in the body? DPP-4 inhibits those GLP-1 peptides. So if you are inhibiting the DPP-4, what are you actually doing? You're increasing that GLP-1 activity, right? So the way I think about those DPP-4 inhibitors, and I'm sorry if I lost you, I'll say it again. So DPP-4, its role in the body is to inhibit those GLP-1 peptides. If we are inhibiting those DPP-4s, that means we're allowing for more GLP-1 activity. So we're actually increasing that GLP-1 activity, right? So the way I think about my DPP-4 inhibitors is that they're really our GLP-1 agonists. So I think about them very similarly in my head. So again, when we're looking at the pharmacology, what does it do? It really helps stimulate the release of insulin, slow that gastric emptying, increase satiety. It's all the same stuff, so we get the same types of side effects, right? With the GI, pancreatitis, we're going to watch for that. Contraindications, this one is contraindicated in our type 1 diabetics. GLP-1s will not be approved in type 1 diabetics, but it's not contraindicated. We certainly use it for weight management in our type 1 diabetics who can get it approved. But it's not for controlling insulin in that way. Remember, it improves that insulin response and it really stimulates the release of insulin. So it's not used in our type 1 diabetics to manage their diabetes. And it does not currently have a weight loss approved label. Did that make sense? Okay, hopefully I didn't lose you guys. The DPP-4 inhibitors are pretty expensive, but they are another medication option for our diabetic patients. And again, I kind of group them in my brain with those GLP-1s. All right, you guys, let's go to the next slide. We're going to go to slide 8. And this one we're going to read together because it was a little bit too long for my Slido poll. We're going to read it together, and the poll is open for those of you who read a little bit faster. And you can go ahead and answer in the poll. A patient presents with a desire for medical management of weight loss. The patient has been working on diet and lifestyle changes, but has not had much success in trying to improve type 2 diabetes. Which of the following diabetic drug classes may be helpful? Select all that apply. Are we A, B, C, or D? Remember, if you're sitting for your ANCC boards, you are going to get select all that apply type questions. There are a lot of different types of questions like drag and drop, select all. With their select all that apply, for the last couple of years, they've been telling you how many are correct, which is nice. So in this scenario, there are 2 correct answers. What do you guys think? Now I'm going to open the poll. Beautiful. You guys are getting the hang of this poll. I like it. So what do you guys think? What's going to help with medical management of weight loss for this type 2 diabetic patient? They've been working on diet and lifestyle, and now they're coming to you and saying, I need a little bit more help with medication. What medication, what 2 medication drug classes would you consider in this patient? So a lot of you are saying GLP-1s, and I think that's pretty common and obvious now with all the publicity with GLP-1s. But what's that second drug class? And a lot of you, 83%, are saying SGLT2s. You guys are listening. I love it. It's sticking in your brain. Yes, SGLT2s are going to be helping with weight loss, initially water weight, but over time, research is showing that it really does help with weight loss. And then how could you eliminate the other ones? Remember, TZD, sulfonylureas, is going to be more weight gain as the side effect. Awesome job, you guys. All right, moving on. And so again, if you're taking these questions through our Q bank, you're going to get really robust and thorough rationales that come out. We're talking to it today, so you don't have to sit there and read the slide. But when you're going through the Q bank, you're going to get all those rationales. So you can sit there and read through the slide. And if something doesn't make sense, go back and study it. It's really helpful. All right, so now insulin. Before I dive into insulin, let's go to our next poll. Tell me your comfort level. Oh, good. I used the emojis on this one. I knew I had to throw in emojis in one of my polls today. But what do you guys think? What is your comfort level with managing insulin? Are we at the crying level? Are we at the, oh, maybe I'm a little confident? Are we at the, I'm a superstar? I see patients like this all the time on my floor or in my clinical practice. How are we feeling with insulin management? Yeah, absolutely. And so there's no shame around that, right? When I was entering my clinical practice, again, I saw a lot of type 2s in federally qualified healthcare centers, but and a lot that we had to start on insulin because insulin is cheap. You have other issues with getting ways to get patients to check their blood sugar levels or inject the insulin. But insulin itself is cheap. So oftentimes this was our go-to. Even with that experience, when I entered clinical practice on my own, I was like, oh my God, what do I have to do if I have to prescribe insulin, right? It's scary at first. Like you're telling someone to inject this into their body. I didn't get comfortable with it until I went into endocrinology, and I really had to get comfortable with my type 1s who are really hyper managing their insulin to the point where they're teaching me, right? Because they know it so well and they've been dealing with it for a lifetime. So it's perfectly okay. I see some people are feeling pretty confident with the smiley face. I love that. That's great. Some people are still feeling in that scared range, and that is normal. That is okay. That's why we study as groups. That's why we talk about it, talk about our experiences so that we can learn from these clinical scenarios. So with insulin, you will be expected to know this, right, as a primary care clinician, because this is within our wheelhouse. And so the best way to study insulin, Archer has created this beautiful graphic. I really want to credit them to this wonderful graphic that really helps break it down into type. You have your generic names, you have your onset, your peak, your duration. It's a really nice tool or study graphic to have when you're going through these different practice questions. What I want to group together for you is our short-acting insulins, our intermediate, and our long-acting. That's the way I want you to think about it. That's the way I think about it. The difference between our short acting and our rapid acting, really, we use rapid acting mostly in our type 1 diabetic patients who are pretty hyper vigilant about their blood sugar management. And what that means is they don't wait for the insulin to reach its peak and they keep giving themselves insulin, and we call that stacking. And so that's going to be more for our patients who really we should start them on a rapid acting to help them see their results on their blood sugar levels so that they're not continuing to stack insulin. But typically, you'll be probably starting someone on a short acting insulin if you're really thinking about mealtime insulin. But the way you want to think about it is how long will it take to really start taking effect? How long does it take for it to hit peak? So this is why we use it at mealtime. It peaks really within 2 to 4 hours. It starts within 30 minutes. So you want to make sure when you're giving a short acting, it's at mealtime, patients are eating because you don't want them to become hypoglycemic. It peaks within 2 to 4 hours and it can last anywhere from 5 to 12 hours. So sometimes with our patients, we just give morning, maybe at breakfast and at dinner time, right? Along with their basal long-acting insulin. But you really want to be focusing on when you're thinking about these classes or grouping them, how long does it take to start having effects? So that rapid acting really within 15 minutes, the short acting 30 minutes, so 15 to 30 minutes in those shorter insulins, right? They peak between 1 to 4 hours and they last anywhere between like 3 to 5 hours, maybe even up to 12 hours, depending on the insulin. So that is our first group, our short acting. You have our long acting. So that's what we're talking about with our practice question with that Lantus, right? We know that Lantus lasts 24 hours. So we're not going to be giving this at mealtime. We're not going to be giving this twice a day. We're going to give this once a day for our basal insulin to help with those fasting glucose levels. And with this drug class, it really takes about 2 to 4 hours, but it lasts 24 hours. So this is going to be our basal that we have across the board. And then we can add those short actings for mealtime if they just really need a little bit more help in the managing those blood sugar levels at mealtime. With our intermediate acting, this is also falling out of favor. So why is that? Look at the onset, peak, and duration. So onset takes about 1 to 4 hours. Peak is about 4 to 12 hours. That is a wide gap, right? So it can peak one day at 4 hours, next day it could peak at 12 hours. And the duration, look at this wide gap, 10 to 24 hours. So some days it can last about 10 hours, some days it can last 24 hours. So with our intermediate acting, we really see patients' blood sugar levels kind of all over the place and they're peaking and dropping, and you're just chasing these blood sugar levels. We really have shied away from using intermediate acting insulin, at least in the practice and the endocrinology practice with the endocrinologists that I was trained with. So you really want to be looking at mostly when you're managing patients with that long acting and those short acting for mealtime, long acting for the basal insulin. So let's practice a question together. I'm going to launch the next poll. Let's go to, where do we go? There we go. All right, let's read the question together. So a patient with type 2 diabetes has been taking oral medications, but their A1C is still elevated, 9.5%. The patient weighs 199 pounds. The nurse practitioner is starting Lantus, and the nurse practitioner will correctly dose this at which of the following? Is it A, B, C, or D? And I apologize, I was talking about this as if we had already talked about it, but I did it on the Instagram live this morning, and that's why I thought we already talked about it in this lecture, but that was at our live session. So some of you were like, what are you talking about with that Lantus? But in this question, the patient is a type 2 diabetic. They've been taking oral medications. We're not getting their A1C under control. It's still at 9.5%. They're telling you that you're going to be starting them on Lantus. We know Lantus is a basal insulin, so how are we going to correctly dose it? Let's see what you guys said. Absolutely. So the answer is C. And why is the answer C? They try to trip you up with the weight. If you calculate the weight, yes, this patient may eventually need 18 units of insulin, but we would not be starting them on more than 10 for safety. Remember safety with pharmacology. And so we're going to slowly titrate them up by 1 to 2 units every 3 days, but we're going to start them on no more than 10. Right off the bat, you can eliminate A and B because those are mealtime. Remember, Lantus is your basal. And so it was between C and D with that 24 hours. That's how you're going to give it. All right. So I'm going to quickly take a brain pause before we get into our case study to wrap up our lecture today. If you like those questions, they all came from our question bank. We have a free trial on it. Give it a try. If you like it, you can purchase it by itself or you can bundle it with those on-demand videos that I've been referencing. We also have Sure Passes, which bundle all of it together, including our live reviews and our mentoring, and it has a pass guarantee on it. So a lot of great products that we're really building out here for you for Archer. And I really invite you to join this community because there are a lot of wonderful things happening and coming, and I don't want you to miss it. So make sure you're connecting with us in our community, scan this QR code, and stay up to date with what we're doing and what's rolling out, like these pharmacology lectures. All right, my friend. So let's meet our first case study. This is our friend John Doe. He's a 58-year-old male. We know his height and weight reaches a BMI of obesity. So we know there's some things we need to already right off the bat work on with our friend John. We have a medical history. He's a type 2 diabetic, has hypertension, hyperlipidemia, has a positive family history of cardiac. So dad was a type 2 diabetic and died of age 62. So we really want to make sure John does not go down that same path. Look at his risk factors: lifestyle, sedentary, consumes a high caloric diet, minimal physical activity. Not good, right? We have some things we need to work on with our friend John. He comes in today saying, I'm really tired. You ask a little bit more deeply about more questions. Says, I have been frequently urinating and increased thirst. So what are we thinking right off the bat with our friend John? You guys can put it in the chat, but what are we worried about with those chief complaints? What are those signs of? He also is doing a really good job of checking his blood glucose levels at home, and they are consistently high at a fasting blood glucose levels averaging between 180 to 220. Throw in the chat for me, what do you think those fasting blood glucose levels should be based on the ADA? And I just realized, I'm sorry, my slides were still on the Slido, but now you should be able to see my case study. So what do we think our fasting blood glucose levels should be? He's at 180 to 220. What does the ADA recommend for our type 2 diabetic patients? What do you guys think? Yeah, we really want to get him into the 80 to 130 range for those fasting blood glucose levels. Absolutely. He's on metformin already. Yay, kudos to John and the provider. He's on lisinopril 10 milligrams, those ACE inhibitors for his blood pressure. Remember, he's a hypertensive patient. He also is a diabetic patient, so we're protecting those kidneys with that ACE inhibitor. He's also on atorvastatin, and his vitals look good today. Labs come back, A1C 9.2%. We're not surprised, right? His fasting blood glucose levels are high. That's pretty on point. And then his lipid panel, LDL 120, that's high. HDL, not high enough at 38. Triglycerides 220. So it's really painting the same picture. He's sedentary, eating a high caloric diet, and we need to work on weight loss. So what do you guys think? I'm going to open our next poll. What are your initial thoughts with our friend John? What do we need to work on? And this is an open text poll, but what do we need to work on? What are your initial assessments? Is he doing well? Is he not doing well? What are we thinking? I see some typing, some thinking, some critical thinking. I like it. Yes, we need to get better blood glucose control. Awesome. What else? Woo, look at all those responses. Awesome job, you guys. Look at you. Yes, we need to work on his hyperlipidemia, his blood glucose levels. We need to be managing his lifestyle choices or helping him see his lifestyle choices. Add another agent. Yes, you guys are awesome. Look at you. Very good. So John's not doing well. You guys pointed that out. You can see my slides good. He's not doing well. His A1C is not at goal, right? He's at 9.2%. He's showing classic symptoms of hyperglycemia with the fatigue, the frequent urination, increased thirst. We talked about that. And poor lifestyle choices. And you guys talked about what we should do next. We should start him on a second agent. And so I've already said metformin's my favorite medication. He's already on metformin. Great. Let's add a second agent. He's maxed out on the metformin. I personally would add an SGLT2 inhibitor for our friend John. Remember that cardio and renal protective properties. He's got hypertension. He's got hyperlipidemia. He's got a family history. We're really going to protect his heart. Let's get him on an SGLT2 inhibitor. Benefit of that is weight loss as well. So we can get his blood sugar levels down, maybe get him some initial weight loss to really spur that conversation about his lifestyle choices. And then educating him on those lifestyle choices. We're going to be working on that little bit at a time, right? Are we going to do all this in this first appointment today? No, right? That's too much. You're going to overwhelm him and he's not going to come back. We're going to take those low-hanging fruit. We're going to talk to him about adding that second agent, that SGLT2. When he comes back, he's like, hey, I have lost weight. This is great. And then maybe we're going to dive a little deeper and be like, let's talk about that. How else can we support that, right? And then we're going to praise John. He's doing a good job, my friend, checking those blood glucose levels. Maybe somebody said previously, maybe we can get him on a continuous glucose monitor. We'll talk about that at a later time. But really, biggest thing is we want to be focusing on the pharmacology and the non-pharmacology with our diabetic patients. We want to avoid these complications on a microvascular level as well as a macrovascular level, right? We really want to protect his heart and his kidneys. We're going to be doing routine screening to make sure we're staying on top of that. And biggest thing with the hypoglycemia, we want to make sure he has hypoglycemia awareness. All diabetics have hypoglycemia awareness and they know what to do when they see those milder signs or symptoms. Awesome job, you guys. So remember, I went really high level today with a lot of the pathophysiology. You can go back to previous webinars. You can go to those on-demand videos, but you definitely want to make sure you understand the pathophysiology when you're getting into the pharmacology. It's going to make a lot more sense that way. So utilize a lot of those on-demand videos, utilize the question bank, utilize all this free content through our social pages. Don't miss out on that. Today, we focused on pharmacology. In the past, like I said, we've done the anatomy, physiology, pathophysiology a little bit deeper. But you have access to all of this, so you're in the right community, you have the right support group, utilize that. For those of you who have to hop off because it's 12:30, I understand. For those of you who want to hang on for a couple more minutes, I just wanted to show you what's to come for our next endocrinology pharmacology lecture. We're going to get deep into thyroid pharmacology. We're going to talk about things like thyroid hormone replacement, the different drugs and the indications and the mechanism of action and the prescribing considerations. So I'll leave you guys with that. And I will finish with our last two polls of the day, one of which being, how did you guys like Slido? Scale of 1 to 10. Good. Maybe I should do this one happy and crying faces too. But how do we like Slido? Did we love it? I see a lot of responses with loving it. That's great. You guys, I love it as a provider because I'm like, this is great. I feel like you're there and we're interacting. I really enjoy it. So I'm glad you guys are enjoying it. And then I also want to open this Slido for you guys and let you free text and let you really drive this product that we're building out for you. But what content would you like to see in the future with these live webinars as we're building out all this content for you? And you guys had told us pharmacology back in November, and that's why we've really beefed up pharmacology. And so we really want to hear from you and help support you in what you need, because we know that a lot of different schools do it a lot of different ways. A lot of NPs get different clinical experiences before they enter their own clinical practice. So we want to make sure that we're supporting you as the nurse and as the future nurse practitioners. So you guys want to see a lot more about professional practice, a lot more OB help for our FNPs. Our wonderful Rachel Ward is our expert in reproductive health. So hopefully, I'm sure she'll make sure she'll put some more webinars around OB for FNP on the calendar for next month. So that's great to hear. Pediatric and vaccine schedule, yes. I just did a pediatric lecture last month. So again, go to our Facebook page, go to our YouTube channel and watch those. We talked about pediatric and vaccines. So absolutely. And I'm seeing a lot for professional practice. So that's great. And then pulmonary management. Okay, awesome. So a lot of great feedback. I really appreciate that, you guys. Thank you so much. We're about 3 minutes over, so I want to be respectful of your time. I'll let you guys go, but thank you so much for your participation today. I really enjoyed talking to you, and I hope to see you at our next webinar. Have a wonderful day, and good luck to those who are testing soon, and have fun in your clinicals. Get as much of the hard cases you can, just ask for the really hard cases when someone's they're being responsible for you. That's good. Ask for those really hard cases. But you guys are all doing great. How to select one answer. So maybe some test taking tips. Absolutely. Yeah. And our live review does a really good job of also not just going through all the body systems, which you need to know, but it also does a really good job of talking about test taking tips, test anxiety. So our 3-day live review is really helpful, and a lot of students love using it, not just for prepping for their boards, but getting prepped and feeling more confident in their clinical rotations. So absolutely. Diagnosis and care plans, yes. And that's why we're trying to work a lot more case studies into our lectures, just so you guys get a chance to really participate in diagnosing and putting together the case plans. So you have to critically think through it. You'll see a lot more of these case studies coming down the line. How did you guys like the case studies? Would you like to see more, less case studies in these lectures? What do you guys think? If you're still with me, I see you guys are still with me. I love that. More case studies. All right. Very good. We will bring you guys more case studies. Awesome, awesome. Well, thank you so much, you guys. Thanks again for joining me on live this morning and joining me for the actual lecture. That was a lot of fun. And you guys have a wonderful Wednesday. I'll see you next time.